You're listening to In Good Health, the trusted news source for medicine, science, and technology. I'm Elizabeth Westfield.
I'm Mayan Vasta Betancourt.
And I'm Greg Johnson. This week, how the Special Olympics is working to improve healthcare for all people.
The thing that I think we don't appreciate enough is how, when we make society work for people with challenges, we make it work better for all of us.
But first, the condition that causes a loss of sensation in your hands and feet.
Some people feel just numbness. I pulled thumbtacks out of the bottom of people's feet because they did not know that they had stepped on one.
All that and more this week on In Good Health podcast. The spinal cord acts as the central hub for the nervous system. It carries nerve signals back and forth between the brain and the rest of the body. It needs energy to transmit the message all the way down to your toes, especially for taller individuals. And any imbalance in this process can lead to some devastating effects.
So if you have too much blood sugar around, the nerve becomes unhappy. It's like having too much waste and it can't function normally. Too many lipids, too much waste, it causes oxidative stress. These little powerhouses or mitochondria up here no longer travel down to the tip of your toes. Your toe nerves have no energy, and so they quit functioning. And slowly over time, they wither and die, literally.
Which is what causes peripheral neuropathy. Dr. Eva Feldman is the Russell N. DeYoung Professor of Neurology at the University of Michigan. She's one of the world's leading authorities on neurodegenerative disease. But when she first established her lab more than 30 years ago, she was advised not to focus on neuropathy.
I was told, Dr. Feldman, please don't do neuropathy. It's not common enough. It's really somewhat too rare. No one's going to be interested in it. And now, as you know, 50% of individuals, nearly 50% have neuropathy who have any aspect of the metabolic syndrome because we have grown. We are an overweight, much more obese nation than we were when I first started.
There are different types of neuropathy, but peripheral neuropathy is estimated to affect more than 20 million Americans. It occurs when the nerves stop getting enough energy to work and begin to die, causing a loss of sensation and function.
Peripheral neuropathy is a very slowly progressive process of loss of function in your sensory nerves. It usually starts in your very distal toes and over years will slowly progress up your leg until below your knee, and then it will end in your fingertips. The symptoms of peripheral neuropathy, what you as a patient feel, really can vary from person to person. Some people feel just numbness, but no pain. Many people feel fairly excruciating pain, and the pain also may come and go. Worse at night, worse if the feet are touched, worse if it's cold. But the symptoms can be so, I'll have to say, severe that if someone loses all sensation in their feet, they can step on a thumbtack and not know it. And have I seen that in clinic? Oh, yes. I pulled thumbtacks out of the bottom of people's feet because they did not know that they had stepped on one.
Feldman says the treatment and ability to reverse the damage depends on the type of peripheral neuropathy.
So one way to think of a sensory nerve is to think of an extension cord. And so that the nerve is the wire in the extension cord, but an extension cord also has insulation around it, as does the nerve. So the nerve is insulated, and that's known as myelin. And then the wire is known as an axon. So there are two different types of peripheral neuropathy. One is axonal, so it just affects the wire. And that is commonly seen in prediabetes, diabetes, and certain vitamin deficiencies, for example. That is much harder to treat, except for treating the systemic condition, such as diabetes, prediabetes, high blood lipids can cause it, thyroid disease, vitamin deficiency. You can also, though, have the wire working fine, the axon, but have the insulation known as the myelin become disrupted. When that becomes attacked or disrupted, that's known as a demyelinating neuropathy, loss then of the myelin sheath.
This type is often caused by autoimmune disorders and can be successfully treated with a patient's gain back full function. But when the nerve itself is damaged, Feldman says usually the best they can do is to halt progression, not regenerate the lost nerve. Because of this, it's important to catch the condition early. However, there are often hidden obstacles to prevention and early diagnoses. Feldman was an author on a recent paper published in the journal Neurology that aims to identify these problems. The research, led by Evan Reynolds, looks at the risk factors for peripheral neuropathy and how they differ between races.
It's been reported in several studies that Black and Hispanic Americans have an increased likelihood of having neuropathy compared to white Americans, and we aim to answer the question, why?
Reynolds is an assistant professor of biostatistics and epidemiology at Michigan State University. The team wondered if this difference in increased risk was still present after accounting for factors like having diabetes, obesity, and high blood pressure.
What we found is that Black Americans did not have a significantly larger likelihood of having neuropathy compared to white Americans. And so what this likely means is that the increased prevalence that we see of neuropathy among Black Americans is likely caused by the fact that these populations have increased likelihood of having some of these risk factors that underlie the condition.
Which is helpful in knowing exactly what to target to prevent cases of peripheral neuropathy in this community. Unfortunately, Hispanic Americans didn't show the same outcome.
We accounted for as many known risk factors as we could, and yet they sort of maintain that increased risk of having neuropathy. And so we need detailed studies of larger populations of Hispanic Americans to figure out why that might be.
It could just be that there are risk factors the team didn't think of, or it could be an underlying genetic component to the condition. However, Reynolds does believe that a main factor driving this population's increased risk of peripheral neuropathy could be food insecurity. It's a factor that often leads to people choosing cheap calories, a decision that usually results in a poor diet. In fact, Feldman says that saturated fats is the real enemy to watch out for.
So those individuals who have a diet high in saturated fats had worse neuropathy in that paper. And that's a really important point because saturated fats are a very poor source of energy for the nerve. And the nerve is unable to really metabolize saturated fats by the mitochondria, the powerhouse, and turn it into energy for the nerve. If you are a patient and you are mild, that you are overweight, you have poor source of diet, you really don't understand what's happening to you. Like, why are my feet becoming numb? Why am I having pain? And if you can see a healthcare provider and have access to healthcare where that can be explained to you, and you can have a better understanding, well, I really do need to try to lose that 10 pounds or 15 pounds. I do need to make these dietary changes. I need to inspect my feet at night. Simple recommendations by healthcare providers really changes the long-term outcome of neuropathy.
Feldman believes that our nation's weight gain has had a big influence on the increasing rates of peripheral neuropathy in Americans over the last few decades.
So being overweight is a BMI between 25 and 30, and obesity is a BMI greater than 30. Currently in America, 30% of adults are obese, frankly obese, and another 30 to 35% are overweight. So we now have 60 to 65% of our population that carries a big risk factor for neuropathy, and that is obesity. And usually with that, hand in glove comes the prediabetes, diabetes, the high lipids, hypertension, so all the other risk factors.
Which is why diet modifications are a huge component to prevention.
I really believe that these healthy lifestyle habits can prevent a lot of these metabolic conditions, such as obesity or even type 2 diabetes. And ultimately, those conditions can then prevent the likelihood of having neuropathy. So if I were to implement a broad change, it would really be to increase our physical activity and improve our day-to-day diets.
Which means that this could be yet another application for GLP-1 receptor agonists. In fact, Feldman believes that these compounds will be complete game changers for the field of neuropathy.
The results are supposed to come out soon, where they're looking at the effects of the GLP-1 receptor agonists on brain health, independent of the weight loss, but also it's being looked at on nerve health, even independent of the weight loss. So, it could be two things. It could be not only losing the weight, getting rid of the bad saturated fats, returning energy to be more normal, being more eumetabolic. But there also might be a direct effect of this family of compounds on the nervous system.
And this is only the start of the research. While the information Feldman and Reynolds gained from this most recent paper is important, they were only able to pull data from 1999 to 2003. They pulled publicly available data from the National Health and Nutrition Examination Survey, which only assessed peripheral neuropathy during those 4 years.
It was a really cool opportunity to look at a large database, and now we're attempting to replicate these findings and hoping to replicate these findings using more contemporary data too. And one of the data sets we're actively using is the National Institutes of Health All of Us research study, which is a large, comprehensive electronic health records-based database of Americans.
This database gives researchers access to the demographic and health information of more than 800,000 participants, which Reynolds is hoping will help answer some of the lasting questions from his research paper. One area he's actively pursuing is looking at how someone's risk profile changes over their lifespan.
An example of this could be, is it really having obesity since you were 18 years old and having sort of a consistent risk throughout your whole life that's important? Or if you all of a sudden become obese when you're 50 years old, does that give the same amount of risk? We hypothesize that it doesn't. And so that's an active area that we're looking to explore.
You can find more information about Dr. Eva Feldman, Evan Reynolds, and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our executive producer is Amira Zavari. I'm Elizabeth Westfield.
Coming up, a look at how invisible disabilities are treated by healthcare professionals when In Good Health returns. The Special Olympics Health Program has provided athletes with access to high-quality, informed health screenings for decades. But within the last 10 years, it's homed in on a few key areas, including creating a system that's more equitable for people with intellectual and developmental disabilities, also known as IDD. However, Dr. Dimitri Christakis says the organization has realized that to truly make an impact, they need to address this issue for all people with IDD, not just athletes.
Special Olympics has 600,000 athletes in the US, about 6 million globally. But that's a small fraction of people with intellectual and developmental disabilities. Even if we were in the business of being healthcare providers, which we're not, we're merely screeners, our organization doesn't have the bandwidth to solve this problem. It needs to be solved by healthcare systems and by societies themselves. And it can be, it just historically has not been a priority.
Christakis is a pediatrician and the chief health officer at Special Olympics. Special Olympics reports that, on average, people with IDD die 16 to 20 years earlier than the general population due to unmet medical needs. Christakis says many of these conditions are preventable or at least manageable with timely access to effective care. In an effort to improve health systems around the world, Special Olympics recently published a global report that focuses on 11 sites in 9 countries. The paper first assessed the current experience people with IDD have in these different systems. While some countries do a better job than others, Christakis says they all have gaps in care. The global report shows that most people with IDD don't make their own health decisions, and only about half always understand their healthcare provider. He says that in the U.S., a driving factor of these challenges is our current reimbursement model.
Doctors in the United States are reimbursed by and large, according to the condition that they are treating. So if I am a dentist and I am seeing a child for a preventive dental visit, I'm paid a fixed amount, whether that child is neurotypical or whether that child has intellectual and developmental disabilities. And the fact of the matter is that it takes longer to do a preventive visit on someone with intellectual and developmental disabilities. It takes considerably longer if you spend the time needed to make sure you deliver it in a respectful and compassionate way. And yet the reimbursement is not commensurate with that additional need. And what that ends up creating is a system where there are many dentists and many doctors who simply choose not to treat people with intellectual developmental disabilities because it's not as lucrative.
But the problem goes even deeper than the financial aspect. Christakis says there's a huge lack of training for healthcare providers on caring for people with IDD. Sadly, this is an issue that spans generations of physicians.
I finished medical school over 30 years ago, and I got no training. I got no training whatsoever in the care of people with intellectual developmental disabilities. I got all of it when I started practicing medicine as a resident. Sadly, it's still the case that fewer than 50% of medical students get any training in the US in the care of people with disabilities. That's all disabilities, not intellectual and developmental disabilities in particular. So you're not adequately compensated. You don't feel very well trained. It shouldn't come as much surprise that there's a paucity of doctors that are willing to take people with IDD. And when they do, they don't do as good a job as they should.
David Duncan has experienced this incompetence firsthand. He began competing in the Special Olympics in 2012 and is now the chairman for the Global Athlete Leadership Council. Duncan's been steamrolled by dentists who refused to believe he was telling the truth and at times ignored altogether.
They would explain it to my mother because it assumed that I can't understand. It's something that I may be struggling with. So if they're doing a procedure and I'm feeling a lot of pain, I tell them that I'm feeling pain or I make a sound. They just think, oh, he's special, so he doesn't know what he's understanding. Or this procedure normally say, I guess it would not hurt a person without IDD, even though I think it would. So they think that I don't know what I'm saying or experiencing.
He's since found one he trusts who takes the time to fully explain any situation and answer Duncan's questions thoroughly. There are still times when he has to advocate for himself, a skill that he's worked hard to build over time.
When I was younger, I used to shy away from certain experiences because I realized that persons didn't want to speak to me because I have a speech impediment. I don't always speak clearly, and sometimes I feel that I'm just some sort of alien. So I want to stay by myself, but I have a younger sister. She's passed now, but she used to speak up for me.
Duncan says he got a lot of strength and confidence watching his sister advocate on his behalf. And as he got more involved in Special Olympics, Duncan continued to build the courage to speak up not just for himself, but for his peers as well.
And I learned that my voice matters. So Special Olympics opened my eyes to that a lot, that I can use Special Olympics as a platform to advocate for persons with IDD.
That's not to say that guardian advocates aren't important, but even when a guardian is present, people with IDD should be given the respect and dignity to have agency over their health. Unfortunately, Christakis says this advocacy from any group isn't enough to create the needed change.
They're self-advocates and then they're guardian advocates, and both are important. But sadly, they're not sufficient by themselves. Advocacy only gets you as far as the person you're advocating to is willing to let you go. So it has to come from both places, from both entities, from people with intellectual developmental disabilities and from the larger healthcare system.
The good news is these changes don't require a complete overhaul of our system. Christakis says people with disabilities would have a much different experience if our healthcare system simply prioritized properly training primary care physicians.
1 in 6 children have a developmental disability in the United States. So it's hardly rare. It's more common than asthma by far. There's a lot more training for dealing with asthma than there is for treating people with intellectual and developmental disabilities.
In an effort to lead by example, Special Olympics offers opportunities for physicians to receive this training by volunteering in the athlete screening programs.
We take physiotherapists, podiatrists, pediatricians, audiologists, ear, nose, and throat doctors, and we train them in the care of people with intellectual developmental disabilities. They come to our events, they screen our athletes, they see how wonderful they are. They get, in many cases, their first in-depth experience to the care of people with IDD, and they leave as better clinicians for caring for that population.
The program has trained more than 300,000 providers and students in 60 countries. And though inclusive care is strongly advocated for by the disabled community, Christakis says it's something that will enhance every patient's healthcare experience.
The thing that I think we don't appreciate enough is how, when we make society work for people with challenges, we make it work better for all of us. And let me use an example outside of healthcare for this. So if you put curb cuts in so that people with wheelchairs can access sidewalks, people with bicycles can do it, people with walkers can do it, toddlers can do it more easily. Everybody, in effect, benefits. So with respect to intellectual and developmental disabilities, one of the things that they need is things to be explained to them in a way that's more readily understandable. One of the biggest complaints that everybody has with their doctor is that they talk over their heads. Some people complain that they are too condescending to them, but the bottom line is doctors need to learn how to communicate better to the patient that's in front of them. And teaching doctors to speak in plain language, more importantly, teaching doctors to be attuned to how well their patient or their patient's family understands them is essential to people with intellectual and developmental disabilities, but it's absolutely beneficial to everybody.
The Special Olympics Global Report is just the first phase of evolving health systems all over the world. Now that they've collected this baseline data, the organization is now partnering with each of the 11 sites to see what changes will be the most impactful. Those sites will ideally turn into case studies for other health systems to model their own practices after. You can find more information about Dr. Dimitri Christakis, David Duncan, and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.
In Good Health returns in just a moment.
And now, a Progressive ad brought to you by Progressive Insurance. Drivers who switch to Progressive could save big with Progressive. This has been a Progressive ad from Progressive. See if you could save at 1-800-PROGRESSIVE or progressive.com.
Medical notes this week. How can we save babies born with HIV? Experts estimate that about 1.5 million children have HIV around the world. Standard treatments of antiretroviral therapy start when kids are 2 to 3 months old. However, research published in The Lancet HIV has found greater success when the medication is given in the first 48 hours of life. This method aims to suppress HIV and keep infants off of antiretroviral drugs for longer periods of time instead of the daily dose many patients deal with. We're overusing salt, and not just in our pasta. Human activity has been making the Earth's air, soil, and fresh water saltier, according to research published in Nature Reviews Earth and Environment. Industries like mining, agriculture, and construction have rapidly accelerated Earth's natural salt cycle. This abundance of salt can negatively impact our water supply. Technology is only as good as its creator. Wearable wellness monitors can be extremely helpful to monitoring and managing health conditions. However, research in the journal Health Equity shows that many devices have a racial bias. For example, PPG sensors that monitor heart rate are much less accurate on darker skin tones. The scientists hope this paper informs makers of medical technology and reduces instances of health disparity. And finally, is it time to invest in a bird feeder? Scientists are just starting to study how bird feeding impacts humans. Our connection with nature is an important aspect of our mental and physical health, and feeding birds can be achieved whether you live in the city or more rural areas. Scientists want the human element to be considered when wildlife agencies decide on bird feeding regulations. The research is published in People and Nature. And that's Medical Notes this week. I'm Mayan Vasta Betancourt.
Thank you for joining us this week and every week as we break down the science stories you need to know. You can find all of our past segments and guests on our website at ingoodhealthpodcast.org or wherever you listen to your podcasts. Follow us on Instagram, Facebook, and X for more behind-the-scenes content. Tune in next week for another edition of In Good Health.